Good morning. This is a post-fall huddle pertaining to an incident with Mr. June who fell this morning. Staff members that are present are me. I'm Tammy Martin, a primary nurse, the UAP, as she is assisting the patients in this area with care, and the patient and his daughter, the charge nurse, physical therapist, pharmacologist, and respiratory therapist. The situation this morning is Mr. June's daughter rang out the call bell as instructed by me and the UAP to assist her father with ambulating. Her father needed to void and to have a bowel movement and needed assistance to the restroom. His daughter waited, and after 15 minutes of no response from any staff member, she attempted to assist her father to the restroom with his walker. He then fell to the floor and was crying out in pain, which alerted me and the UAP, and we rushed to the room, and finding Mr. June on the floor on his right side, yelling out in pain. The provider was notified, and an order was placed for a stat hip x-ray, which revealed a right-sided hip fracture. The patient was then returned to the floor, and the provider ordered an orthopedic consult and morphine for pain. The background on Mr. June: he's a 65-year-old patient admitted for treatment of a UTI with IV antibiotic therapy, as the previous oral antibiotic therapy has been ineffective. He is also oxygen dependent due to a diagnosis of pulmonary hypertension, and he is also unsteady on his feet, and he is supposed to use a walker when ambulating and frequently forgets due to his diagnosis of dementia. He uses chairs to steady himself and other pieces of furniture, and his daughter constantly has to remind him to ask for assistance when getting out of bed or up from a chair, as it is difficult for him with standing. He does live at home with his daughter, and the assessment has Morris Fall Risk Scale. Score is 85, which indicates a high risk for falls, as anything greater than 45 indicates a high risk for falls. The room was cluttered with furniture, oxygen tubing, and IV pole and tubing. Mr. June is also on levothyroxine for his antibiotic, which also causes dizziness and fainting, and sometimes it can also cause irregular heartbeats. So that puts him at a risk just for the pharmacology effects. I apologize. He is also on continuous oxygen therapy, so we need to find a better way to supply him with the oxygen tubing and keep it from cluttering the floor and entangling him to prevent him from tripping. Also recommendations I include are: we need to place a sign on the door as well as on the chart and in our handoff reports to the next staff of the fall risk with Mr. June. And we need to eliminate the physical hazards in the room, make sure that IV tubing is out of place when not in use, as he is receiving his IV antibiotics once daily, so we can make sure that IV pole and tubing is up and out of the way after the dose has been administered. We need to provide him with non-skid footwear to assist with slippage on these floors. We need to leave the call bell as well as his urinal and bedpan within reach. We may want to consider moving Mr. June closer to the nurses' stations as he will need more supervision as his family members won't be here at all times. And we also need to take into account that just because the patient has a family member, that they are still at risk for falls, and that the family members are not equipped to assist patients with unsteady gaits and who are in the hospital with illnesses from falls. We need to make sure and document any changes in his cognitive status, and we need to make sure that that is provided to his primary care provider as well as the oncoming healthcare staff. And basic steps we need to make sure is that we are promptly answering call bells. It's unacceptable for a patient to wait 15 minutes, and I do take responsibility for that as well. We need to incorporate routinely, hourly rounding on our patients to ensure that their needs are met if they need to be up to the restroom or if they need something to drink or food, or making sure that they're safe. And we also need to incorporate education from pharmacology, as Mr. June is now going to be on morphine, which puts him at a higher risk and is a sedative, as well as can cause dizziness, and hypotension would be enough. And we need to perform orthostatic high blood pressures on Mr. June so we can ensure that the fall wasn't related to orthostatic hypotension. We need to make sure that the wheels on the bed are locked and the bed is in the lowest position, and leaving the call bell within reach, and instructing the patient as many times as we need to on how to use the call bell and to wait for assistance when needing to be up. And respiratory, we already covered that. Physical therapists need to be involved so they can evaluate the patient's gait and any other assistive equipment that he needs when getting up to the restroom and to build his strength. And as well as we're going to have the orthopedic consult that'll help us instruct to better ways of care for a patient with a hip fracture. Thanks everyone for coming, and thanks for the input that you provided, as well as making it more about resolving issues of patient fall risk and not pointing fingers at each other, and ensuring that our patients are receiving the safest, best possible care that they can.